What we know about back pain, it can have a devastating effect on people's lives. One of the things that we try to do is build optimism. We often say to people, your spine doesn't have a great blood supply. It needs movement for its health. So you need to be able to move. You need to be fit. You need to be strong. You care for your whole health, and you will limit or reduce your likelihood of these pain events. To me, that's probably the most important message for your listeners, to don't give up. And often the most important things are the kind of things that you can learn to do for yourself. You don't need fancy equipment to do this stuff. You need a skilled clinician. You need a mirror. You need good communication skills and good coaching skills to deliver this intervention, not fancy technology.
Welcome to the Spine MDT. I'm Anthony Ghosh, a consultant, spinal neurosurgeon and founder of the Spine MDT. And I'm absolutely delighted today to have an interview, a chat with Peter O'Sullivan. He is a professor of allied health sciences at Curtin University, Western Australia. Internationally, he's highly recognized in musculoskeletal physiotherapy as a researcher and educator in musculoskeletal pain, and has published well over 300 papers. He's also pioneered cognitive functional therapy, which we're going to talk about today. And in the spine care community, he's extremely well renowned. So welcome, Peter. I hope I got that bio right.
Yeah, pretty close, Anthony. Probably the only other thing is I'm only half-time academic. The other half I work in the clinic. So I've got a foot in the real world, so to speak, as well as in the kind of academic world. And that keeps me humble, I think.
Yeah. And that's right. So you're still seeing patients and continuing with that experience. So what I want to do with today's chat is basically go through some basic things, debunk a lot of the myths that are out there that patients with back pain and spine problems are seeing. Yeah. So should we start with, we talk about non-specific spine pain quite a lot. Can you just explain to patients what that actually means?
Yeah, so it's probably a term that doesn't sit well with a patient with pain, because they will say to you, my pain is very specific. It's right here and it affects me in this way. And so I think it's a helpful term for clinicians to understand that actually there's no underlying progressive pathological process involved in that patient's presentation. It doesn't tell us that there isn't a specific problem. It's just that it's not about pathology. And so it's really a classification of exclusion rather than of inclusion. And it just alerts the clinician to explore very broadly around other biopsychosocial factors that might be driving the person's pain disorder.
Yeah, so it's when we've excluded a serious pathological underlying condition.
And it's really important for a clinician to kind of, number one, alert them that they don't have to refer that person, but they can manage them, but actually to explore all the other important dimensions that might be driving their pain presentation.
And around that, let's go through some of the myths around it. Let's start with posture. I know that really gets you rolled up. Tell patients the whole nonsense about posture.
Well, it's such an interesting area. Like I was just doing an interview this morning actually around this. And my experience as a young physiotherapist is I was indoctrinated in the importance of posture, like taught to sit up straight and shoulders back, chin in, engage your core, keep your back straight when you lift, don't lift like a crane, all that kind of stuff. And my own personal experiences, I had an injury pretty early in my career and got into trouble. And I started adopting these very upright guarded postures, and I got into a real pickle. And I realized, someone mentioned to me one day, they said, why are you holding yourself so awkwardly? And I realized I'd adopted these highly protective, rigid, upright postures. And then subsequently in our research journey, we've looked at posture in all kinds of ways, sitting posture, standing posture. We've looked at it at a population level, at an individual level. We've looked at lifting posture. And essentially what we've found is that there's a lot of variability in posture out there, but there isn't any evidence for a specific posture that will protect you from pain or that will relieve you from pain. There's a whole variety of ways in which people posture themselves. What we do know, though, is that when people develop pain, particularly if it's disabling and distressing, they tend to guard their body more. They tend to protect it more. So they're probably more guarded and protective with their postures. They tend to lift more squat-like and upright and are less relaxed in the way they move. And so the whole posture story has probably reinforced a lot of unhelpful beliefs and also behaviors that where people with pain often start being blamed that it's because of their bad posture. When they try to address these posture issues, it often doesn't help. And so leaves them sort of stuck in this loop of going, well, why aren't I getting better?
Yeah. And also, like when people slouch, that's just your paraspinal muscles relaxing. I always
100%,
tell patients, you don't walk around with your biceps
100%.
Flexed all day.
Absolutely. 100%.
That's just what we do when we relax. You can't tense them up all day long.
Exactly. And actually we've found in some of our case data that, and in this latest trial, it hasn't been published yet, but essentially as people improve, they tend to relax their bodies more. They move more freely, they move quicker, they're less guarded, less protective. So protecting your back is usually a signature of someone who's, maybe fearful or protective or lacking confidence. But as we build confidence back in the body, we use it in a whole variety of ways. It's something we would encourage.
On that same category of patients, another thing that gets thrown around is core strength and core stability. Now, shamefully, I use that term, but I think obviously that's often misunderstood as what people really mean. You've 100%. Done some studies on it yourself. So tell us a bit about that.
Yeah, well, we would say to people, it's good to be strong in your core, but it's not cool to protect, to guard your core. And I think what often we see, and we've seen this in some of our clinical studies, is that people become overprotective. And one of the things that happens in the body is when you have pain in the back, you tend to guard your core. You tense your core and tense your back. And it's like a bit like the clenched fist. It makes you stiff and it loads your tissue more. So, it's normal to engage your core if you're pushing a door, if you're doing a push-up or a sit-up, and it's good to be strong, but it's not normal to guard your core when you sit, you stand, you bend. That's not normal.
Tense up, have it tense
exactly.
up. Yeah.
And that over-tensing or over-protecting kind of creates often a vigilance or an over-focus on protecting, thinking people protect or unload their back using their core. Well, actually, they're stiffening their back and increasing load in the back. And it can make the muscles around their body way less efficient because they're just constantly working, like the clenched fist analogy.
And in that category, in that subcategory of patients, a sort of chronic back pain with no specific underlying pathological cause that you can find on either imaging.
Yeah.
Does core strength training help?
Look, we would say it's almost like an unraveling and then a building confidence back. So we take people on a journey of not protecting their bodies during normal basic movement. So what we know with people with pain, often they report pain when they sit, when they stand, when they bend, they lift, when they walk. These are not high load activities. And in those activities, you don't really need a lot of core strength. And so we would often, if someone is overprotected, we'll teach them to relax in those movements and then build strength when it's needed. And so, for example, if someone's, pushing a really heavy shopping trolley or a pram up a hill, you need core strength. If you're sitting up out of bed, you need core strength. So we will use it in a task-specific way to teach them to be strong when they need their core, but not to overuse it when they don't need it.
And I suppose what you're discussing now is part of the cognitive functional therapy. So can you explain a little bit about that then? Yeah.
So there are probably one of the key things I think underpinning it is we know that everyone's pain is individual. And there are a number of factors that can influence a person's pain. Our thoughts around pain, we know, can influence our pain. Our emotional responses to pain, the way we protect our body or use our body can influence our pain. Our lifestyle, how much sleep we're getting, how physically active we are, our social environment, if there's got social stresses, can influence us. Our other health factors, our mental health, our physical health, we're carrying extra weight. All of these different domains we know can feed into pain. Same with pathology as a domain. And so we go through a process in examining the patient of kind of exploring all of those domains. And then we have what's called a kind of clinical reasoning profile where we go, okay, what are the key factors that are important for this person? And we explore them both in interview and when we examine them. So we examine the things that are important for the person. So let's say, I saw a chap yesterday. He can't sit. He can't stand. He's having trouble sleeping. He's struggling to bend and lift. They are the things that we examine for that person. And so it's very functionally targeted. And we observe for protective behaviors. We observe if they're over-guarding themselves, if they're over-tensing themselves, which this guy was doing. And then we kind of map for the patient. There are 3 pillars within the intervention. One is what we call making sense of pain. So because you can't provide a, single diagnosis for back pain, we provide an explanatory model of saying, look, for the chap yesterday, his pain emerged at a time when he was highly stressed, was very anxious, he wasn't sleeping, and he developed a pattern of overprotecting his body when he stood and became fearful and avoidant of doing it. So we would kind of help him understand how his beliefs and emotions and behaviors are driving an overprotective process within his nervous system, sensitizing the structures, etc. Then the second point is what we call exposure with control. That's taking the person back to sitting, standing, bending, lifting, lying, and teach them strategies of regulating their nervous system through breathing techniques, body positioning, relaxing, moving, and build confidence for them to get back to the things that they want to do. That's the exposure with control piece. The third element is around lifestyle factors. So for him, sleep was a really big issue around giving him strategies around relaxing in bed and rolling, but also re-engaging in physical activity based on his preference. So that was important. And then re-engaging with work, which is something was avoiding doing as well. So within that whole framework, we kind of target the making sense bit, the kind of embodied bit around, pain is an embodied experience. So building confidence back in the body and then addressing the lifestyle factors, but it's entirely goal orientated. So we target the things that are important for the patient. It's their agenda that we target.
Yeah, so it's very patient tailored. Although you've got these pillars and all those different angles, you're tailoring it to those needs.
So it's not a generic off the shelf program. And
in the trials you've done in the studies where you've compared it to what we call the standard treatment, which includes, core strengthening that we discussed as well as manipulation therapy. Tell us a bit about the trial and what you noticed over what time frames.
Yeah, there have been a number of trials now. The first trial was conducted in Norway, and that compared this approach to more traditional, these were highly skilled manual therapists, so manual therapy and exercise, and a lot of that was around core strength exercise. And the effects were large for reductions in pain and disability, and the effects were sustained out to 3 years actually. Which is unusual in a pain population. We see that most pain interventions tend to regress. You lose the effect around 6 months often in most pain interventions. And that's because we explicitly teach people how to self-manage their pain and how to self-manage flare-up. So we put them in the driver's seat of their care. So that was one trial that was done. There was a follow-up trial that was carried out in Ireland, and that was comparing individualized care versus group-based care. So similar components, but it was more targeted towards a group rather than the individual. And that trial demonstrated that the individualized approach was more effective at 6 and 12 months, particularly for pain-related disability. We just published the largest trial, which was in the Lancet last year, and this was in Australia. There was a 2-arm trial, 2-center trial, and we compared it to usual care. So usual care was anything that the patient wanted to get. So it was a whole combination of factors, but could be seeing the GP. A lot of them were on medication, seeing the chiropractor, physio, massage therapy, etc. That we didn't constrain what care they got. And we saw again in that study that the CFT arm showed large and sustained reductions of pain and disability. Patients were more confident. They were less frightened about their back. They had more positive beliefs about their back pain, and it saved a lot of money because people were getting back to work.
And what time frame was that, Peter, that you got those outcomes?
Yeah, so we looked at, we tracked outcomes right through the intervention, but our primary outcome was at 13 weeks and our follow-up was at 12 months. And actually we have unpublished data out to 3 years now, which we're in the process of writing up.
And as early as 13 weeks, you noticed...
Yeah, well, the biggest effect, actually, there's a big improvement at 6 weeks. So the largest change happens in the first 6 weeks, and then it kind of levels off. But what was interesting is even between the 13 weeks and 12 months, people were still improving. So it's almost like once they learnt these strategies, they were able to kind of practice them and reinforce them. And that's really encouraging for us because it tells us that we were empowering those people to do something different, think differently, behave differently, re-engage in life differently. And our qualitative research supports that they were doing that. They were thinking differently. They were more confident in their body. They weren't as frightened. They felt empowered to self-manage. And that's really important.
Yeah. And I like the way, like you say, you didn't compare it. Your control group wasn't a very specific treatment like core strength or manual therapy because you're trying to compare it to real life situations. And I've seen it, in my practice, patients with back pain will go online. Like you say, they'll end up either with their GP on medications. They could end up in a chiropractor's practice, an osteopath, a physio. They don't really know, or a spine surgeon, and so these are like real life situations you've compared it to. That's brilliant.
And the other thing that was, the other thing that was particularly interesting is a lot of people had actually given up. They'd just gone, I've done everything. And commonly, they've been scanned, they've been told they had degenerate discs, as we commonly hear. They tried a whole lot of treatments and just gone, I've had it, I've done it. I've given up. And that's a concern for us as a society, because that's a large group of people sitting in our communities who have literally given up on care because they don't think there's anything left. They just have to accept it.
That's right. And I think it's a good time to mention to patients, but when we talk about non-specific back pain and scans, patients are probably saying, well, I've had a scan and I've got degenerate discs, so that doesn't include me. What I often tell patients is that in most adults, there is no such thing as a normal MRI scan. It's a very sensitive piece of kit. By default of being human, our discs do wear and tear, and often use the phrase, whilst all these what they're describing are age appropriate wear and tear changes that should be considered as normal. In addition to that, one of your trials, actually, you went a step further, and I think is it the Restore trial, whereas in addition to CFT, cognitive functional therapy, you started using sensors as well around the muscles.
We did. And we did it for two reasons. One is there'd been another trial, Peter Kent, who led the Restore trial, had done a small trial looking at the use of sensor biofeedback. So that was giving people feedback to how they moved and whether they, how they engaged with their body. And so we wanted to see whether that augmented the treatment. The other thing that we were interested in was to measure people at every treatment session, to go, tell us the thing you can't do. So, very commonly bending, lifting is a common thing that people struggle with. So we use the patient-specific function questionnaire, which basically says, tell me the thing that you really struggle with. That's what we measured. So that was measured at each treatment session. What that then allowed us to do was to see whether changing the way someone moves, because it's one of the key pillars of the CFT approach, is to teach non-protective movement, to see whether that was associated with an improvement in their clinical outcomes. And we're writing that up. That paper's about to be submitted actually now. But we didn't find, interestingly, that the sense of biofeedback enhanced the outcomes at all. They were exactly the same. And that's interesting for us because, and I think it's quite good in some ways, because that technology is quite expensive. It's not that accessible. And what it tells us, you don't need fancy equipment to do this stuff. You need a skilled clinician. You need a mirror. You need good communication skills and good coaching skills to deliver this intervention, not fancy technology.
Yeah, the clinical assessment is the most important. And actually, 100%. On that note, how useful do you find? I mean, in your practice, do you find imaging useful at all?
Um, Great question. Look, I had a guy in yesterday came in, he had a L4 radiculopathy, he had loss of power and reflex and, imaging. He'd got a history of cauda equina syndrome. Imaging for him was important. But in the absence of neurology or serious pathology, I wouldn't send someone for imaging because it doesn't change the treatment. It can frighten people because invariably all of our spines come back with stuff on them. And then the problem is patients Google it. I don't know about the UK, but in Australia, people will get, at their scan result, can access their scan results. And then they go Googling, disc protrusion. And it's like, then they completely freak out. So, I would always sit down with the patient and explain the imaging once I've examined them. And that's key because this guy yesterday, he had two protrusions, one compressing S1 and one compressing L4. He had normal neurology at S1, but he did for L4 so I could say, well, look, that's not relevant to your clinical picture now, but this one is. But you're resolving, and that's really good. Your pain's reducing, your function's improving, your power's coming back. Let's just monitor you, and the natural history is good.
We treat the patient, not the scan.
100%. 100%.
I find it, for me, it's a two-edged sword. It has some benefits. So, like you say, a lot of patients that come and see me have had a scan privately. They've got their report and they have freaked out.
Yes, exactly.
And often I explain, and like I said earlier, I'm explaining that look, these findings should most of the time be considered normal. But then there's another group of patients that have been passed around. They've been to see various therapists. And they just want a scan and they just want that reassurance. And I find in that setting, it's useful to say, look, here's your scan. We've done it now. And I can explain to you why this is normal. And I find 100%. That positive reinforcement does actually help.
And I don't know if you know, there was a beautiful study published last year that randomized people with acute back pain to MRI scanning. And they either explained all the details, like you have a degenerate disc, fissure, arthritis, disc bulges, etc., or they said this is normal for your age. They then followed those patients up. They didn't control any treatment. They all got treatment. And the people who've been told that their pain was because their disc was degenerate and disc bulges and all arthritis were worse in their physical health, their function, their mental health, their confidence. Those who've been reassured that it was normal were significantly better on every parameter. So actually there's very good evidence to support what you're saying.
Yeah. And now that we're on that, so that's the sort of non-specific stuff. You've also done a lot of work on segmental instability. So let's talk a bit about that now. So now we've got a subgroup of patients where we've got some segmental instability, and some of these things we talked about, like specific exercises, may actually be of benefit. So in your words, explain that.
Yeah. So that's interesting because in the early part of my career, I had a very strong view on a lot of the symptoms that we were seeing being linked to instability. And I've really shifted my view on that now. So in the early stages, I was kind of engaged in very specific targeted exercise training. And so we ran my first trial, part of my PhD was for people with spondylolisthesis. But if I kind of reflect back now, I think what we were doing was pretty similar to what we do in the CFT approach. We were reassuring them that it was safe to move. We were building their confidence back to engage in physical activity. All the key pillars we were doing. And so I'm less convinced now as a scientist and as a practitioner that I would treat those people any differently than I would someone with so-called non-specific. And one of the reasons we had a trial, a colleague of mine in Denmark worked in a pain clinic where they were seeing people who had not responded to primary care, and they were all scanned. And he used the CFT approach with them, and he reported all their scan findings. And these people had listhesis, stenosis, disc protrusions, modic changes, all kinds of stuff on their scans, and it had no negative impact on their change. These people demonstrated large improvements in pain and disability with the CFT approach. So we didn't see that pathology was a roadblock to engaging in all the key pillars of what we would call good spine health.
Yeah. But with CFT being tailored, am I right, and correct me if I'm wrong, in this category of patients, does that CFT actually include a bit of core strengthening if you felt that patient could benefit with it?
So I'll give you an example of that. So I saw a lady who had just had a child. She had terrible pain during her pregnancy and was actually, she described being in bed rest for a period of time, preeclampsia and pain. So she presented like 3 months after she'd had a child. She was completely deconditioned. She was very weak through her back, her legs, her core. And what she needed was a general strengthening program because that's where her problem lay. And so you're right, within the whole approach of identifying where the factors are and targeting them, if someone has deficits and she was struggling just to carry her child around and pick her child up and just to do normal things. And it was very distressing for her, but she needed a general conditioning program, which involved legs, arms, back, core, the whole lot. That was the approach that we took with her.
Yeah. Just to explain to patients, when we talk about the word instability or spondylolisthesis, imagine, I always tell patients the spine is a stack of bones that sits on top of each other called vertebrae. They're usually aligned. They shouldn't move backwards and forwards. What usually happens, they angulate at each segment. But in spondylolisthesis is when one of the vertebral bodies just sits ever so slightly forward over the other one, and it can move back and forth. And that's by definition, when we talk about instability, radiological instability is when you see that shift between flexion and extension. I've seen patients who've had a spondylolisthesis for years, but it's static, and they're actually okay with it. They're actually okay with it. Yeah. When a surgeon gets involved, it's when measures you've discussed have failed and there's possibly nerve compression.
Yeah.
Sometimes just realigning it with instrumentation can take the pressure off the nerves and, stop that segment moving abnormally. But that's not a sole treatment. I always tell patients that's only a small part of the treatment. Then a lot of the stuff you've talked about still has to complement.
Yeah, it's interesting. And in the Restore trial, we had people who, had not responded to spinal surgery, and we then take this same approach. So, it's not binary as you have this or that. And I think that's the key thing is, caring for someone's whole health is important at any step of the journey, and it can be combined with other interventions.
Yeah. And going back to one of the things you said, like the psychological factors, what's happened in the UK is, as part of pain management, we involve, in the NHS anyway, clinical psychologists have been involved as part of it. And often, unfortunately, that gets misinterpreted by patients as, you're telling me it's all in my head. Yeah. And I think one of the problems is if your sort of treatment is predominantly carried out by physiotherapists who are incorporating that into the whole bigger picture. Yeah. And I think that makes a big difference.
Yeah, it's an interesting area because I think we have an advantage as physiotherapists that we work with the body, and pain is an embodied experience. It may be linked to we will explore a person's beliefs. We'll explore how it's affecting them, how it's impacting on their social world. So that's where the psychological and social, pain, when it's disabling, invariably is distressing, and it can get people down. They're normal phenomena. That doesn't mean it's a head problem. It's just impacting all aspects of their life. But pain is an embodied experience, which means that they need to have an understanding and strategies to manage it so they can get their life back. And so within our trials, we've seen people's mood improve. We've seen that their anxiety levels reduce, that their confidence improves. So getting people engaging in life and confident in their body improves their mental health in itself. But we would never tell someone that their pain is in their head, because their pain is an embodied experience in their back. And so that often backfires. But I think when we work with patients who are, may have other health comorbidities, like mental health comorbidities, we would work in conjunction with the psychologist to support their mental health while we support their spine health and their whole person health.
Yeah. Another area I wanted to discuss, and I think this is something Stuart McGill, another sort of big name in the spine care world, talks about, is the kind of the unstable disc. So you might not have a malaligned spine. So the vertebrae might be perfectly aligned. You've got a disc that's got an acute tear in it. The lining has torn. The nucleus, the stuff, the grizzle in the middle hasn't actually shifted or moved or slipped or pinched a nerve. But often patients do get that acute bout of pain. They've been absolutely fine. They get that acute bout of pain. Over a few weeks, it gradually settles down. But then there's a recurring pattern. After a year or two, it happens again and again and again. I've kind of shifted my thinking a little bit. I've always been dismissive of that concept in terms of, it's a black disc. It's just the degenerative discs that we all have. But there is a subcategory of patients where you find it's that same disc. Every other disc is brightly colored, beautifully hydrated. There's that one disc that's remained. It starts to get inflammation around the end plates, what we call modic changes. And every so often it tears. In that scenario of patients, do you do very specific exercises to target that?
Yeah, it's interesting. I mean, Stu and I have had a few conversations, and we do differ in our views. He probably has a much more structural position around his understanding of pain. Mine is much more multidimensional. What we would say, because we definitely see people where they have, like you described, the modic change. And if you look at the literature, the predictors of the likes of modic changes are things like, pro-inflammatory factors, which might be linked to sleep, depression, abdominal obesity, which we know increases systemic inflammation in the body. If we look at, so we would look at a holistic approach to go, what are the drivers? What might be the drivers? It could be movement behaviors. It could be a lack of conditioning. It could be the fact the person's not sleeping or their diet's poor. So we would kind of package a whole, we put a whole package together to treat the whole person. And often what we know from those changes is their trajectory is often very good. So those inflammatory changes around the end plate or the vertebra between the disc, or around the disc actually can resolve. And that was shown in our Danish study as well, that a number of those people had modic changes and did really well with this approach. Without being specifically targeting the structure, we were targeting the person and all of those factors. And that's probably where I would differ with Stu.
Yeah, I agree. But do you notice there are some patients that they're having an acute bout of pain? The scan shows this torn disc where the radiology report may say it's an acute tear because there's a bit of bright signal in the annulus, in the lining. But they get better, but it happens again and again. How would you get these patients to, in terms of compliance, how do you get them to prevent that episode happening again? Because stop that at the same time, stop them over guarding.
Yeah, that's right. Yeah,
some strategies to prevent it.
So the kind of pathway we teach people to go through is, number one, don't fear your back. So we would often talk about back health, and I think back health is a really useful way. I kind of don't see it any different to, let's say meniscal tear with some degeneration of the knee. So what do we know about that? If you lose weight, if you get active, you get strong, you get moving, those things often settle down. We've shown, like in the original Norwegian study, the reduction in recurrences when people engage in optimizing their spine health, those recurrences often reduce. When you get people active, you get them moving, you build their confidence. So we often say to people, your spine doesn't have a great blood supply. It needs movement for its health. So you need to better move. You need to be fit. You need to be strong. You care for your whole health, and you will limit or reduce your likelihood of these pain events.
And that's what I tell patients who, once they've got over that acute phase, rather than focus on a very specific exercise, I say, look, if you're going to spend money on something, spend it on just generally maintaining 100%. Good health. Get a personal trainer, get a right diet, all these things. Just don't blow your money on mattresses and 100%. And expensive core strengthening programs and things like that. going back to the modic changes around the disc, there's one subgroup of patients that, just to explain that patient, when you've got a single disc that's black, about 15, 20 years ago, there was a big trend, and the surgical community came under fire for this, of just fusing these patients. So they would try and, with that good intention, they would try and do a test called a discogram, where you put a needle into that disc, inject some fluid into it, and see if it reproduces the pain. The trouble with that, you need to do that to a control disc, because if I stick a needle in any disc in your spine, inject stuff into it, you're going to be in agony. Yeah. And there's good animal studies that show if you put a needle now into a normal disc, you are going to dehydrate or degenerate that disc. And in following that approach, when they fuse these patients, tiny number of patients might have got a bit better. The majority didn't. More research has come out now with SPECT CT. If you've got modic changes on an MRI on a single disc, and it matches a CT scan where they inject a special sort of radioactive dye and it shows increased activity around those end plate. If you've failed all of the methods that you've discussed, then in that subcategory of patients, they may benefit from a fusion. But if you follow that process of filtering patients out that way, you'll only operate on a few each year. And I always say to surgeons, if you're operating on more than, 15 of these patients a year, you're probably over-treating some of them. So there is a small subcategory.
Yeah, I kind of see a bit of parallel. We've done research around the knee, I say knee arthritis as well. And, you'll see the bone edema in people who are really inflammatory around, the knee. Now, a lot of people with knee arthritis respond really well to non-invasive, non-surgical interventions of weight loss and getting strong and building confidence and getting active. There's a small group that benefit from, I think we overdo the knee replacement. There's clearly a group that benefit from that. So we're not anti-surgery. What we are, I suppose the question in my head is, what are the drivers of that inflammation? So you've got inflammation around an end plate. Well, what are the drivers of that? So if we're not addressing the drivers of it, we're putting a Band-Aid on. And there's growing evidence around, lifestyle factors, sleep, mood, physical activity, body weight, dietary factors, driving systemic chronic stress, driving systemic inflammation that can target that area. And so I think sometimes we're too quick to go for the invasive approach rather than say, look, this is a journey. And if we can target your whole health, this is cheap. It's non-invasive. It doesn't come with risk. There's no downside in giving this a red hot crack. And that means at least 3 months of working on that process. Because you may not need the other if you do that.
And that's why I think the multidisciplinary approach is what I've tried to do with my practice. I think bringing us all together, the surgeons,
100%. Speaking the same language is the tricky bit.
Yeah. Yeah. That's totally correct. That's right. It's been a brilliant discussion, Peter. You teach this stuff around the world. You've made a big difference. I think it's important we spread this evidence-based treatment that you've sort of pioneered and developed. You travel around the world. You teach this stuff. I think you're in London in June. Is that right?
Yeah, end of June. Running a 3-day workshop in London, and I've been doing that for a while. So James Davis has kind of been a bit involved, and it's interesting.
He's part of our Essex network.
Yeah, we bring in a bunch of researchers who are kind of part of our network, and we meet in London. And so we have a day of research and planning at the same time. But one of the things in that workshop is we bring in people with lived experience with pain, and we kind of track their journey. Some of it's videoed and some of it's live. And so it's not just a talk fest. It's actually real world stuff where people come in and tell their story. And, what we know about back pain, it can have a devastating effect on people's lives. And one of the things that we try to do is build optimism in patients, but also in clinicians, because I think there's there's a sense of, feeling like for clinicians are like, what can I do? What can I possibly do? If this person's had all this treatment, what can I do? But what we've seen in our research is that you can have pain for 30 years. You can have significant pain and be disabled and be distressed, and you can still change. So building that belief in a clinician to transfer that hope to a patient is so important, that we don't give, false hope, but we actually build the confidence and the skills that actually change is possible. And to me, that's probably the most important message for your listeners, to don't give up. And often the most important things are the kind of things that you can learn to do for yourself.
That's brilliant. No, I absolutely agree with you on that one. Look, it's been a pleasure speaking with you today. Obviously, you're a big name in this world. I've been following your work for a number of years now, so thank you.
Great. It's a pleasure to talk to you and to your listeners as well.
Yeah, thank you. So I'm going to put a link to the course on the bio below. If people want to reach out to you, possibly those in Western Australia, how can they do that?
If you Google my name, Peter O'Sullivan at Curtin University, there's a link to an email. The other link that I think is helpful, we set up a website called restorebackpain.com. And that's a website to the Restore trial that was published in the Lancet. And we created a website to make the Restore trial much more accessible to lay people. And there's a site for patients as well. So it kind of there's infographic that tracks the journey of a patient for recovery. And that's what patients have told us. And there are patient stories, videos of people telling their story. And every story is different. And it highlights that everyone's journey is their own. And our job as clinician is to kind of work with the patient to support that journey.
Absolutely. So I'll put a link to that as well below. Well, cool. Good luck with all the rest of the work you're doing. Don't stop.
Good on you. And just a shout out for all the people I work with. It's not just me. There's a whole team of researchers and clinicians, both here in Australia and internationally, who are involved in this work. And there are other wonderful research teams similarly dedicating their time to better support people living with pain, because it is such a tough area. So a big shout out to them as well.
Absolutely. Well, thank you very much, Peter. It's been great. Thank you. Bye.